for Dr. Inder's time that she's joining us today. We're going to leap right in. This is part 2 of the series. Dr. Inder started last month with a really nice comprehensive overview of MRI and MRI technology, specifically in use with the neonatal brain, and focused a little more heavily on term equivalent imaging. And as promised, today she is going to take us through some clinical case reviews and discuss a little more about the preterm infant application for neonatal brain imaging utilizing MRI. So with that, I will turn it over to Dr. Inder.
Thank you so much. Let me make sure I actually can be seen on here. Hang on. There we go.
Okay.
And we
There you are.
And we will flick back to our slides. Okay.
Thank you.
Welcome everyone, and sorry for those technical delays. We are going to start with a series of clinical presentations and try and build some concepts on those about how to consider utilizing MRI. We're going to start with the term infant, and then we are going to move to the preterm. So let's start with a 39-week infant who was born via a stat cesarean section due to decreased fetal movements. The mother had had a pretty unremarkable pregnancy and had negative screens. The APGARs, as you can see here, were 1, 6, and 7. And there were several minutes of PPV, and you can see pretty significant base deficit and passive cooling was started. The infant underwent a standard sort of treatment course with conventional ventilation and INO for pulmonary hypertension, had 72 hours of therapeutic hypothermia. The important thing to note is that the background on the EEG was always reassuring, with a very good looking background. But the baby did go on to have a bit of a prolonged hospitalization. The MRI was done after this. This was the AEG at the bedside, and you can see this very nice kind of background trace with some nice cyclicity present here and a good amount of EEG activity. Now, remember, I do want to say, why are we doing this at day 4? Why am I obsessed with the fact, in fact, that we need to be in that window? And that's because of this graph that we reviewed last time, but I want to touch on it again. In normothermia, the diffusion is going to be most restricted around day 2, and then it starts to normalize pretty rapidly, such that an infant that's not cooled, by about day 6 or 7, you may not see any changes on the diffusion anymore. But even on day 4, if it was normothermia, you'd still hope to see quite a bit of the restriction. In the setting of hypothermia, however, you get a little more time. So between day 2 and 4 is when you're going to see the maximal restriction in the diffusion coefficient. And so that is the time that's most useful for us. As you start to wait, and I hear all the time about people who wait out to 7 days, you're up here. So you're already several percentage points lost in terms of looking at diffusion and expecting it to tell you if injury happened and where that injury happened. So this was the MRI that was done on day of life 4 in this infant. And you can see on the left-hand side here, we've got T2 and T1 weighted imaging. And here we've got the diffusion weighted imaging, the blurrier looking one with black CSF. And then on the right, the apparent diffusion coefficient with the high CSF, the high water movement with the value calculated of the diffusion. So you can see on the left, on the T1 and the T2, you really don't see any structural abnormalities. You can see that there's a normal, essentially normal brain that's been formed in terms of the hemispheres and the structure. And indeed, on the T1, we can see the myelination in the posterior limbs of the internal capsule bilaterally and normal signal in both of the basal ganglia and the thalami. On the both the B1000, the diffusion weighted imaging, and the apparent diffusion coefficient, it would be bright on the B1000 or dark on the ADC. We don't see any abnormality either. So essentially, there was no abnormality detected on this MRI. And so these parents were told that result. And what does that really mean? Well, when you look at the predictive value that's published for MR, and we'll look at some more of this later on, you can see that it's actually very high, whether you were cooled or not cooled. the sensitivity for abnormality is very high, and the positive predictive value is also pretty high. And importantly, as you can see here, the negative predictive value. In other words, if you don't have abnormality, what is the likelihood that you'd have any abnormality present? And I'm just comparing it down here for things that often people know about. For instance, you do a chest X-ray as an adult to look for pneumonia. There's a positive predictive value of that of about 93%. But for pleural effusion, which we would think is pretty good, it's only 67%. So in other words, MR really ranks up amongst these very accurate diagnostic tests. So the take-home points for that baby is that a negative MRI is very encouraging. We know that it's not uniform and that some of these babies who present with encephalopathy may not have had a hypoxic ischemic insult, and there may well be some other sort of developmental or genetic problem. So it's not 100%, but 80 to 90% of these kids will have a very good, completely typical outcome. However, they should be followed. 20% may have some sort of very mild abnormality, but moderate to severe abnormalities are really extremely rare. And the EEG and the clinical exam, as you could see in this case in particular, the EEG was very, very helpful. But you would be still offering surveillance with early intervention and follow-up in your clinic. Let's look at a different type of case. This is a 40-week infant born by vaginal delivery to a prima gravida mother. Notable for GBS being positive, and you can see here some fetal tracing abnormalities, but the baby came out pretty unexpectedly depressed with APGAR, as you can see, 1, 3, and 5. Here is the cord gas. The base deficit was 14 and the pH was 7. So no doubt in most people's minds, this baby would be eligible with the 5-minute APGAR less than 5 and these gases to be eligible for hypothermia should they have abnormalities on the neuro exam, which the baby did, no spontaneous movements, hypotonic, absent grasp, and no suck. So a pretty significantly impaired exam. And in addition, as I've already alluded to, the EEG was very helpful. It showed a diffuse voltage attenuation, which persisted beyond 24 hours. And so the family agreed to have an MRI done even before hypothermia had been completed to be able to understand what the prognosis may be, because both the exam and the EEG suggested there had been a severe brain injury. And indeed, you can see here on the T2, this being a normal and this being this baby, pretty much nothing to see. Here, the T1, also pretty much nothing really significant to see. But now on the diffusion, you can see all of the cortex is lighting up as white. And the contrast can often be the cerebellum, which we don't have a slice of here. But you can see in this particular picture, the basal ganglia stand out quite differently from the rest of the cortex. And you can see here on the diffusion restriction, this is where the blackness is, but there's also blackness bilaterally in the thalami. This baby also had spectroscopy, and you can see this very striking elevation in the lactate. And this baby, the parents elected to provide comfort measures only, and the baby did pass away. The placenta was found to have multiple infarctions, and on postmortem, there was extensive injury throughout the brain. This is a similar type of baby that I've had the privilege of taking care of that had this type of imaging on day 5. Again, the history was one of placental abruption, actually, with this young mother. And this baby also had profoundly suppressed EEG and a very abnormal exam. And you can see all of the brightness that's lighting up across the entire cortex. And that is also equivalent with this restriction all around the outside of the cortex. And you can see a little loss now of the what we call the T2 cortical ribbon. You can see it's kind of smudged out everywhere. And the other thing that can be prominent, particularly in the early severe cases, is you'll start to see the blood vessels popping out because they are standing out as having sort of normal characteristics. And usually you don't see them. But when you've had this severe diffuse brain injury, then that can persist. This family, unlike the last family, had more difficulty with the decision for comfort care. It took a considerable period of time. So we did get to re-image the baby to discuss with the parents the severity of the injury. And just so you can see, this is what that injury resulted in. So this profound encephaloclastic result with complete dissolution of most of the cortex and just scarred deep nuclear grey matter. And despite that, this baby was in the bed with an abnormal neurological exam, but was still opening their eyes and looking around. The gaze wasn't always conjugate. The tone was, by this stage, markedly hypertonic after a period of hypotonia. And the baby obviously didn't initiate any feeding. And eventually the family did agree to comfort measures only. So just to reiterate again, remember these time windows: normothermia, which is rare now but can occur, and then hypothermia, where we are trying to look for this maximal decrease. So it's pretty rare we will try to ever do any imaging in the first 24 hours, because just like after 7 days, that first 24 hours can underestimate the extent of the brain injury. But when did the brain injury happen? And this is a really complicated thing, because that's assuming everything happened right at birth, right? Which is what those graphs were based on, a series of infants where we knew. And this important paper came out in the Journal of Pediatrics. You can see the reference down here, 2022, and I think is extremely helpful. This came out of Bob Christensen's work up in Utah. And what they did was they took all of the infants who had had the diagnosis of HIE and therapeutic hypothermia, and who'd had a number of nucleated red blood cell counts, and they looked at the association of these nucleated red blood cell counts with the outcomes of their babies, with the hypothesis that if the baby had taken a hit some time back in utero, that the hypothermia would not be very effective. What they found was that about 95 out of 150, so about 2/3 of their babies, had normal nucleated red blood cell counts after birth. And this does come up routinely on the CBC. You don't have to order it as anything extra. And in contrast, about 1/3 of the babies had an elevated count. Documented sentinel events that were resulting in emergency deliveries were always associated with a normal nucleated red blood cell count. So if it was something very acute and nothing had been going on beforehand, these kids had normal nucleated red blood cell counts. And of these babies, about 88% survived to discharge, but the odds of surviving were 3-fold greater when the first nucleated red blood cell count was normal rather than elevated. And normal counts were moderately predictive of the infants having better neurodevelopmental outcomes. So in other words, what they hypothesized was that the normal count after birth was associated with more of an acute insult that was more in a time window that could be responsive to hypothermia, and that these were also predictive of better outcomes. And I now use this as I'm trying to piece together when and what happened to these babies, and I'll show you some cases now. And remember, this is important because hypothermia definitely works well in the 6-hour window, may have a little tiny extension out here into the secondary energy failure, but definitely this is where we want it to get. And if for some reason the insult happened more than 24 hours prior to delivery, which is what the elevated nucleated red blood cells would suggest, hypothermia is probably less likely to be effective. In fact, this was the data from those lamb trials showing that even out at 5.5 hours, there was a blunted effect compared to earlier, and certainly out at 8.5 hours, there was no significant improvement seen in terms of the overall brain injury. I also want to comment on cord gases, and I often hear people say, well, the baby came out and the cord gas was reassuring. Cord gas is only one marker of whether a baby may have had a hypoxic ischemic insult. And indeed, we believe even some of the very acute insults, they may not have had time to have accumulated a lot of lactate. The other thing I'll say is that the baby is better than the cord. So this is a study we did, and on the top panels, you have cord measurements against the maximal encephalopathy score. And on the bottom, you have the baby's initial blood gas taken within the first hour of life against the neonatal encephalopathy score. And what you can see here is that the umbilical arterial pH had actually no relationship to how encephalopathic the baby was. But in the same group of infants, the infant's blood gas pH was highly correlated. So the lower the infant's gas, the more likely they were to have an elevated encephalopathy score. And this could also be seen with the base deficit, which of course is the most important contributor to the pH because it's measuring the amount of metabolic acidemia. And you can see as that went up, then the encephalopathy score went up, but it was even more tight in the relationship with the baby. So if you're at all in doubt, get a gas off the baby. Much, much more powerful than your cord gas. Here's another infant to illustrate these points about timing and scanning. This was an infant we recently cared for who was born at term to a prima gravida mother with an unremarkable pregnancy history, was induced at post dates and proceeded through labor with just some decelerations very terminally, had APGARs of 0, 3, and 3, and you can see the pH 7.04 with a base deficit of -14. However, the baby had a white cell count that was pretty elevated at 40. There was no real marker of infection. And the nucleated red blood cells were above that 97th mark, which is 18. That's the 97th percentile, 18 nucleated red blood cells per 100 white cells, and this baby's was 20. In addition, I really like getting labs at admission. So I don't wait 12 hours to get everything because this is very informative to me. So these were taken within the first few hours of life. The creatinine was already elevated, 1.8, and so was the transaminases. The AST was 995, and this was within the first 2 hours of life. The baby was also noted to have some abnormal movements at the outside hospital, and they're not sure whether those were seizures or my suspicion was they were actually brainstem release myoclonus. But regardless, the baby received phenobarbital, was transferred to us, and the EEG through the first 24 hours remained pretty isoelectric. So we decided and elected to take this baby down to the MRI scanner at about 20 hours of life, presuming that an insult had been going on for some time, given the elevated nucleated red cells and the end organ measures, as well as the fact that this EEG was very flat. And this was the diffusion that we found at that time point. You can see the abnormalities here in the cerebellum and in the brainstem, and these abnormalities here in the hippocampus, all consistent with severe brain injury. And you can see here bilaterally the thalamic injury as well. So this is a profound insult that occurred. The T1 also, interestingly, even though we're at 20 hours of life, was not completely normal. And you can see this highlighting a little bit in the thalami and this patchiness in the lentiform bilaterally. This type of abnormality usually takes a couple of days to be present, but already was visible at 20 hours of life. So for us, this gave the information we needed to be able to talk to the parents about prognosis and make decisions with them. Here's a different type of baby. This was a G4P3 mother who noticed some decreased fetal movements about 20 minutes before going to the hospital. And then she, on her way to the hospital, noticed she was also bleeding. The baby was delivered by an emergency cesarean section, and you can see the APGAR scores here, 1, 4, and 6. And this is what the base deficit was. Not bad, right? Not horrible. But look here, white cell count, platelets, and the nucleated red blood cells were elevated at 24, suggesting something had potentially been going on for much longer. The background EEG was never horrible. It was discontinuous, and it never really changed. And seizures were only noted at the time the baby was rewarmed, and there was no other end organ involvement, no liver, renal, or DIC seen. This baby, however, was dependent upon respiratory support, initially was extubated on day of life 2, and because the baby remained on high flow nasal cannula and CPAP, we were unable to take the baby down to the scanner until day of life 10. And when the baby did undergo imaging on day of life 10, you can see here now on the conventional imaging on the T1 on the left and the T2, This baby has classic severe deep nuclear grey matter injury involving the lentiform, and we'll talk about this more, and the thalami, with absence of the posterior limb of the internal capsule. And the one clue that came from this baby right throughout, and you can see it on the T2, was that this baby had a profoundly abnormal neurological exam, out of keeping with the fact there was no end organ involvement or the discontinuous trace. And what you'll see on these babies is often they're profoundly hypotonic, and that then they emerge with early increase in tone. And you can see here, this is the diffusion. So this is out at day 10 now, and this baby obviously received hypothermia. You can see there's still some restrictions seen even out here at day 10. But importantly, you can see that this is now going down through the brainstem. In other words, this is a degeneration that's going right down through the brainstem, and very prognostically powerful for severe cerebral palsy. When you get to these types of cases, it's really important at all times to be part of a team. And that means that the information that you give to families is really critical. And this includes not just saying, well, gosh, we're going to try and help the brain with cooling, but being honest about what you're seeing on the exam, on what you're seeing on the EEG. Obviously, this needs to also involve the rest of the team, in terms of what you are concerned about, and obviously partnered with neurology about when to call and when to do an MR. The referring provider, if a patient was transferred, the OB team are obviously needing to be updated. And then in terms of neuroradiology, you really need to talk about the timing of undertaking an MR. With this baby that we took down at 20 hours, this was not something that was commonly done, and required a good discussion about why we wanted to image that baby in that window with the MRI team to be able to get the right sequences and take the baby off the blanket for as short a period of time as possible. And then, as you've already seen, the placenta can be incredibly valuable to try and understand why and what happened. And obviously for those babies who survive, making sure they've got the right follow-up. As I've already alluded to, this is the most ignored organ in the human body, I think, and it often is the key of the kingdom in terms of understanding risk for these babies. And more often than not, it doesn't come with the baby if the baby's being transported. But I would encourage everybody who is involved in treating these babies to try and work towards a system where the placental pathology can be available, both to help the families understand what happened and also to provide the best information to the OB team. When you're looking for brain injury in these babies, this is a very nice review article that reviews the patterns of injury, and we're going to go over just a couple of these. We've already seen some of them, the central basal ganglia. We've seen the brainstem and deep grey matter injury. We've seen a global injury. And so being able to really think about what these patterns are and what you would see on the MRI and what their frequency is and what's associated with them. So the central grey matter is often associated with these sentinel severe events, whereas the watershed may be associated with more of a maternal hypotension or chorioamnionitis. So let's start looking at some of those patterns. This is a so-called parasagittal or watershed injury. It can occur, as you can see here, on the diffusion weighted imaging on day 5, early in the anterior watershed between the anterior cerebral and the middle, or it can occur posteriorly, as we'll see in a minute. So often it can be bilateral, but it may be unilateral or asymmetric. And it really is just the area between those two sprinkler zones that is not getting enough blood flow. And so you'll see these lighting up on the day 4 MRI. And then as you follow them out, you'll start to see a little bit of scarring on the T1 out here. And even this is one that was part of a research study that we imaged later and later. And you can see that really now, you haven't got a lot of other impact on the rest of the brain. And this baby has done very well. This is a posterior watershed here, you can see, and it's asymmetric, just affecting one hemisphere. And you can see it here easily on the B1000 diffusion weighted image, not on the T2. And then on day 10 now, we've lost it on the diffusion, but we can see that bright signal now in the posterior region on the T2. What's the clinical pathological kind of correlate? These babies can be difficult to pick up clinically. They may have a little bit of weakness, particularly in the shoulders and the hips, and they can present with seizures, or seizures can be problematic because you're involving the cortical neurons. Later, they can be a little clumsy, maybe have a little bit of academic issues, but overall, relatively, compared to the basal ganglia, they do relatively well. And this is an old paper, but a good one, that looked at these different patterns. And you can see here in the watershed predominant, the average IQ was about 18 points lower than the sibling controls, but still able to be with many of the kids doing relatively well. This is what it looked like in terms of those with normal MRIs, those with watershed injury. And the much more difficult type of brain injury that you've already seen in one of our patterns is that of basal ganglia injury. And these deep nuclear grey matter injuries here, you can see this is so-called mild, just that little blob there, or moderate here with their scarring bilaterally, or severe, like the baby I showed you earlier, involving the thalamus and the lentiform bilaterally. The head of the caudate can often act as a control for you because it's the least likely to be involved. So if you're trying to orientate yourself as what should the basal ganglia look like, you can always look up there beneath the ventricle wall for what does the head of the caudate look like. The other thing that's very important is to look at this posterior limb of the internal capsule and if it's myelinated. And you can see on this lower panel, here's this beautiful myelination bilaterally. Here, maybe it's there. I'm looking really hard. And we would call this impaired. I think there's something there, but it's not completely typical and reassuring. And here, of course, it's absent. You've got the high signal in all the areas of damage and the complete loss. It's almost the opposite markings to what you have in the healthy brain. And there again is this posterior limb of the internal capsule, and here it is absent in a different baby. What does this all mean? Again, this is a beautiful review article that came out of the largest series of these babies that's been followed in the United Kingdom. And these are the babies that just had that one spot or dot, those mild basal ganglia injury kids. And these are the kids that are often, unfortunately, missed if someone isn't really looking carefully in this region. They still have a not insignificant risk of having motor impairment, but it's often in the milder range. So if the plic is intact, they'll walk by 2. If it's not, if it's a bit equivocal, they will have a good chance, but they may be delayed. And then they can also have the typical problems that we see with basal ganglia injury, but if they have them, which is not as common, they're likely to be in the milder range. As you go up the severity of basal ganglia, now the chances of cerebral palsy are closer to 60 to 75%. And if the plic is present, then it hopefully will be on the milder range where they'll just need a lot of assistance to get walking with splints and other things. But they also start to have more likely to have difficulty with feeding, particularly in the neonatal period where they may have pseudobulbar palsy, which also relates to impairment in communication and these other deficits. And of course, in the most severe lesions that we've seen today, including the baby that I presented from our own unit, the chances of cerebral palsy are almost universal. And they are usually associated with severe spastic quadriparetic cerebral palsy with gastrostomy tube, inability to independently communicate. And we can't even truly evaluate the cognitive performance because the children are so severely impaired. And so these children, their lives are very heavily burdened. When do you do these MRs and what is the right way to think about this? I've presented lots of different considerations, so maybe I've just confused everybody. But what I would say is the Newborn Brain Society put out these beautiful guidelines saying that really between day 2 and 4, depending on whether it's going to influence your decision making. So if you are going to have a discussion with the family about potential comfort care, then you can interrupt therapeutic hypothermia to get that imaging done. Otherwise, most people will wait until just after rewarming around day 3 to 4. if there is any disconnect between what the imaging shows and what the baby looks like. So the imaging looked great, but the baby does not look great, or the imaging looked terrible and the baby looks great, then we would recommend you repeat imaging, and you should wait at least a week from the time of the first imaging till you repeat the imaging. And that probably needs to occur in at least 20% of all of the babies. People have started to get a bit more sophisticated about how to evaluate these scans. And this is, and again, a beautiful commentary that was written by Linda DeVries and her team, looking at the commonest scoring systems that have been developed over the last 25 years for assessing MRI. And what I've been really walking you through is sort of the original Barkovich, looking at the difference between basal ganglia injury and parasagittal. But because now with cooling, we see a lot more diverse types of injury in terms of white matter and cerebellum and other things, these more extensive scoring systems, both developed at Wash U by Trivaldi and then in the Netherlands with Lauren Weeke, have been developed that are a bit more comprehensive in terms of also assessing things like the cerebellum, doing spectroscopy in the Weeke score, really evaluating more regions in a more thorough way. Do they make a difference? And this article that I already cited has really tried to compare these different types of scoring systems and looked at how many babies, and you can see relatively, it's not very large numbers actually, that were evaluated in any of the studies using these scoring systems where they compared more than one scoring system. And there's only 4 of these papers, and this particular review accompanied this particular paper from 2024. But essentially, what you can see is the more detail you get, the better your prediction gets. So if you take the more sophisticated scoring systems, the area under the curve or the R-squared values were higher than the more simplistic scoring systems. And so being able to more comprehensively evaluate the brain does appear to be a better approach in terms of both predicting motor outcomes and cognitive outcomes. But overall, you're talking about areas under the curve that are approaching 80%, 70 to 80%, which is pretty outstanding. So let me pause for a minute and see if there was any specific questions related to that. I know that after, and I apologize that last time with the question and answer session, I unfortunately had completely lost my voice, so was not able to be present. But I know people asked a lot about timing of the scans, and I hope that I've been able to address that in terms of your thinking about that. Are there any other questions before I move on to quickly talk about the preterm? Okay, we'll move forward then. Let's talk about the preterm infant. I think MR does have a role, obviously, and there's several things that I think it really is helpful for. One is the extent of hemispheric injury in a so-called grade 4, or a parenchymal venous hemorrhagic infarction. And you can see here, there are 3 parenchymal venous hemorrhagic infarctions, right? On the right, a very small one, middle, a medium-sized one, and this is obviously a large one. And, the involvement of the posterior limb of the internal capsule, the likelihood that this is going to cause hemiparesis can clearly be visualized on these images, with this obviously being significant in the larger lesion, but it can't be visualized on ultrasound to do that. And that's important because when you look at the outcomes, I often hear people get very sad about grade 4s, and so do I, but when you look at the actual outcomes of these infants, if they do survive, so this is the largest series again from the Netherlands, 213 of these babies. And if you look at, most of these lesions were focal in the parietal area. And if the children survived, which about 70% of them did, the chances of cerebral palsy were only 50%. And if they had cerebral palsy, the vast majority of this was only in the upper extremity in terms of spasticity. So 70% of them only had either upper spastic cerebral palsy or mild upper. And so if you are able to better define the brain lesion, you're able to better prognosticate and help the family. In addition, cerebellar hemorrhages, we know, are difficult to pick up on cranial ultrasound. They're extremely difficult if you don't look at the cerebellum with an ultrasound, but even when you do, we know that it's only detected in about 2 to 8%, but around 15 to 20%, particularly the babies less than 28 weeks, will actually have this on routine MRI. And these smaller cerebellar hemorrhages are truly only detectable on MRI. And you can see here a unilateral cerebellar hemorrhage, which again is important to know about because it carries prognostic significance. And you can see this here in Kathy Lamperopoulos's review, where the elevated risk for both cognitive and motor development is around 3 to 4-fold increased. Perhaps Emma's greatest visibility really lies, however, with white matter injury. And you can see here the gradings that we utilize in terms of these just focal punctate lesions, or these more significant punctate lesions that often lie in line with the posterior limb internal capsule, linear scarring, or obviously cysts that can be seen if the ultrasounds are done at the right time. These were prognostically powerful, and you can see the overall cognitive score at 2 years in the babies with these higher grades of white matter injury and the risks of cerebral palsy. So we had published this now getting close to 20 years ago, looking at these different patterns of brain injury. And you can see in the bottom panel here, different types of cerebellar hemorrhage, different types of blood still present from IVH, and different types of white matter injury. And overall, all of these things contributed to the risk. People often say, but cranial ultrasound's just as good, Terri, you should just use that. There are all of these trials that have done head-to-head comparisons between ultrasound and MRI. And in all of these, whether you are looking at sensitivity, specificity, positive predictive value, or negative predictive value, MR outstrips them. The one exception to that, in terms of not blowing it out of the water to a certain extent on sensitivity, was the NICHD trial. And that may relate to the kind of evaluation they did of the MR, which was extremely unique, shall we say, in terms of what they were looking at. So this algorithm was proposed nearly 5 years ago now, that for preterm infants, particularly those less than 29 weeks or less than 1,000 grams, that in addition to the ultrasounds that should be done regularly, that an MRI be done at term equivalent age, and that be done during the hospital stay, and that the parents be updated about the findings of that to enable risk profiling to assist families with understanding the need for rehabilitation after discharge alongside the presence of brain injury. So brain injury is really important because you need to define it, and you won't be able to define it, as we've already seen, unless you do imaging. But in addition, we've now got a lot more focus on brain development as well as injury. And we know and have seen for a long time, 20 years now, that the preterm brain somehow does not develop in the same way as a healthy term brain. That there's this kind of room for growth around the brain in these babies, with ex vacuo dilatation of the ventricles and those large extraaxial spaces, and this simplistic form of folding, which is often called the diffuse encephalopathy of prematurity. But you can evaluate that, and you can evaluate it by some very simple measures that can capture the distance between the hemispheres and can measure certain things, such as the size of the cerebellum. And we've shown that smaller brains often relate to impaired growth and multiple birth, and that brain width does relate to cognitive outcomes. enlarged hemispheric space is often commoner in males and those babies who have received dexamethasone, and that fentanyl use is also associated with reduced cerebellar width. And we need to know these things. We need to be able to know for our individual baby what impact our treatments have had on their brain growth and development. Scoring systems exist for these preterm babies to be able to look at some of the simple things. Do I see cysts? Pretty rare now. Do I see focal punctate lesions? Are they focal or extensive? Is the posterior limb internal capsule myelinated? Just like we've looked at in a term baby. Is the corpus normal, or is it thinned, or is it globally thinned? And are the ventricles dilated? And is the width of the brain reduced? You can also look at the folding and the increased extraaxial space. You can look at the size of deep nuclear grey matter and the size and the presence of hemorrhage in the cerebellum. When you put all those things together, you can see that it's not uncommon for our babies to have some type of abnormality. About 40% will have mild global abnormality, 20% moderate, and 7% severe. And a lot of this is contributed to by the commonest area of injury, which is the white matter. But it's not uncommon also for the children to have impairment in these other structures. Why does it matter? Because when you look at their follow-up, and this is 7 years after they left the neonatal intensive care unit, their performance academically, whether it's IQ or spelling or math, related to the presence of these abnormalities. So global abnormalities, white matter abnormalities, deep grey matter abnormalities, or cerebellar abnormalities, these were present. They were associated with about a 7 IQ point deficit. So as Dr. Volpe and I have tried to pin this together, we've tried to point out that this is what the preterm brain often looks like compared to the healthy term-born brain. And you can only really evaluate all of these things through thorough imaging. We know the brain is undergoing this rapid period of development, this rapid period of cortical folding, and that the premature brain, particularly in the temporal lobe, does not develop the same way as the term baby. And in fact, that persists, and you can see it 7 years later. And in fact, kind of scaringly now, as we follow our cohort, it becomes more and more prominent with age, that what we have left as the stigmata of their neonatal experience becomes more exaggerated in terms of the difference between typical brain development and brain development in adolescence and into early adulthood. There are other ways to look at this, and I'm just very briefly going to explain what resting state correlations are. So when we have background brain activity going in your brain or anybody's brain, there are different areas of the brain that the blood vessels are firing at different rates all over the brain. But some of these areas are firing together, as you can already see. If we put a seed region in one of these areas, we can try to identify who else is firing at the same rate as I am, whose blood flow is flowing in the same frequency, in the same way that my area of the seed is. And then I can have correlations between those. And that's what we call it, a resting state network. We're not making the baby do anything. We're not activating a network. We're just saying when you're lying asleep in the scanner, what areas of your brain are spontaneously firing at the same speed measured by the change in the blood flow. And we've been able to pick this up after we realized that what we were eliminating when we were looking at our functional connectivity, our functional scans, was actually not noise, but real information. So when we do this and we look at different things, we put a seed point in one motor cortex, the other motor cortex. We put a seed in the visual cortex, the other visual cortex lights up. We put a seed in auditory, the other auditory cortex lights up. These two things aren't physically connected to each other, but for some reason the brain organized itself so that these regions had, they were in tune with each other. They were ready to fire together. They're not wired together, but they're ready to fire together. So when you look at premature babies and term control babies, it's really interesting. Just putting an ROI in the motor cortex of a healthy term baby, the other motor cortex lights up. In the term equivalent baby, it's trying, right? But there are certain systems that are definitely a lot less mature. And you can see that here, that when we look at the adult and the term brain, there's striking similarities about the way the brain is already organized at term equivalent, just emphasizing how important it is that we get it right in the neonatal intensive care unit, because there's these dramatic similarities, whether it's supratentorially or infratentorially in the cerebellum. But as I've said, we already know this is coming online while they're with us in the NICU, and you can see that these networks are being refined across the period, particularly in this third trimester. So we can see that those networks are coming online when they're in the NICU with us. But things interrupt them. And one of those is white matter injury. And so if there is even just a focal area of white matter injury, we can see disruption in the networks around that area. And this is just comparing term babies, term equivalent babies and term controls. We can see gaps that exist even between premature babies with and without white matter injury. If you look at those babies that have these correlation coefficients and say, well, does it matter? You know, what is the predictive value of those things, whether you're in an uninjured or an injured brain? And you can see that particularly with injury per se, that if you lose those connections or that synchrony, then that is associated with impairment by standard deviation downward in your performance, and that can be very profoundly down. So those kinds of techniques are coming. They're not here yet, but I did want to present a little bit of what the future may hold for us. So in summary from what we've covered today, so we can leave a little time for questions, MR is a powerful tool. It really can help us a lot, but you need to be able to understand when you're using it and what question you want to ask of the scan. You need to be able to be comfortable really to apply the tool based on the clinical context and the question you're asking of the scan. It's a great risk modifier, but it's not 100% for individual prediction, because it's going to combine with the clinical scenario, and it's going to combine with whatever you're going to do to try and rehabilitate that brain. So for instance, if you find injury and then you do aggressive rehabilitation, you are going to alter, that's the whole point, the trajectory of the relationship between the scan and the outcome, because you've used the scan to change what you were going to do. And you might say, well, our babies are all going to get early intervention anyway, so it doesn't make a difference. And unfortunately, sadly, that's not true. Even if you refer them and you think they're going, very good data now has shown that at least 50% of our babies, even when they're referred, when they come back at 6 or 12 months, haven't seen any provider, because the family don't understand. They don't really understand that there's injury there and they need to be doing this rehabilitation. They don't really understand what early intervention even means, which I don't actually either. I really do understand injury and rehab. And so I think we just need to be aware of the terms we're using and how we're using them. And obviously from a research point of view, MR is very powerful to be able to tell us how and where and what may be changing, and then what we could be doing about that to make a difference. So I'm going to escape out of that and open it up to see if I can be more helpful to talk about anything related to either those term brains and the utility of MRI in the setting of term neonatal encephalopathy, particularly with or without hypothermia, or in the preterm infant, in particular, trying to understand how to complement your cranial ultrasounds and how to use it as a kind of a risk profiler for your babies to understand, you know, what you want to be providing, knowing that this period of brain development, particularly in the neonatal intensive care unit, is so critical. And in fact, if I could have my wish, I would have these kids imaged at 30 to 32 weeks, knowing that I can get the therapies into the neonatal intensive care unit then to be able to try and start that continuous rehabilitation of these brains that may be already disrupted. And with that, I will pause.
Thank you, Terri. That was, I'm sure, very informative for everyone. I'll give everyone a moment to formulate their questions. If you have any questions, as a reminder, if you touch your screen, the panel will come up across the bottom of your screen. You can use the Q&A panel to submit your questions. We'll give you a couple of moments to type those in if you do have questions for Dr. Inder. And we'll give everyone just a second. Terri, thank you. That was a very, very nice presentation. All right, we have one question. If you bring an infant early during cooling to MRI, are you concerned about reperfusion?
Reperfusion, I think it's just
Reperfusion, okay.
corrected. Yeah, that's a really good question. And obviously, you want to be able to do this as quickly and as efficiently as possible. Hence the joy of imaging with things like the aspect scanner that might be on the unit, where you can literally go around the corner and pop the baby in. I think the key is, what's the risk benefit? And for us, the other thing about these babies, because you're predominantly taking down babies you're very concerned about, are that they will stay cold. They don't warm themselves up. So this baby that we recently took down last week, we were down for about 45 minutes, actually, by the time we took the baby down and got them in the scanner, even though we had an abbreviated protocol. And when we got back, the temperature on the baby was 32.5. So the baby had not dropped significantly and not warmed up significantly. So we felt like that was absolutely information that was critically important. Because when you wait, as happened with that last baby I showed you, that the scan was only done on day 10, beginning a conversation with a family on day 10 about comfort care when a baby's extubated and lying there in the bed, in my experience, is very challenging. And yet that baby's going to sort of face very severe spastic quadriparesis and difficulty. Beginning a conversation on day of life 1 or 2, very different, right? Very different when the baby's still on the ventilator and still needing a lot of support. So those are the babies that I feel it's really worthwhile considering it early, because I think the risk benefit favors going. And I don't know that I've ever seen any true reperfusion injury per se. And you can always potentially find a way to get a rectal temperature. But in my experience, as I say, when I've taken a number of these kids to the scanner, it's not been a major problem.
Okay, thank you. Next question. For the babies with HIE, do you prefer that reports from radiologists come with a score, such as patterns, such as central pattern, global pattern, mixed pattern, or a more descriptive report?
That's a really good question. And I think it depends on your radiology team. The problem is that often we have a large number of neuroradiologists that are reporting the images, not one, i.e. our favorite one, who might be familiar with the scoring system. I do think it's important that the neuroradiologists become familiar with, and I would encourage the WIKI score, because I think it is the most comprehensive and best. I think they should become familiar with the fact that now we like to look at all these things, the cerebellum, the brainstem, the basal ganglia, the white matter, and the cortex, so that they, even if they're describing each of those domains, even if it's not a score, that you can see that being comprehensive in their evaluation. I worry sometimes that if they're looking at it really quickly, and those global injuries, just so you're aware, those global injuries I showed you where the whole brain lights up, I've seen those missed because neuroradiologists have looked at it really quickly and they haven't used the cerebellum as like a control tissue, and they miss that the whole brain is injured. So you've got to be really careful to make sure they're being very thorough, and they've got to be aware. Please don't just put HIE, please image, because they've got to be aware you're really concerned. They've got to be aware that this baby is severely encephalopathic with multi-organ dysfunction and a flat EEG. Put that in your rec, because that's going to highlight to the radiologist, oh, I got to look really carefully at this because this sounds bad. You know, if it's a baby where the EEG is unremarkable and, you know, there's been, you're relatively reassured, then you can even put HIE clinically mild, EEG normal or something, and, you know, allow them to have as much information as you have so that you can help them to be able to read the scan. And I don't think we do that very well for them.
That's interesting. Next question, can you tailor fit a rehab intervention based on areas of injury
Yes,
detected
you
on the
can.
MRI?
You can, and that's a really good question. And the classic example is just starting to think about what I showed you with grade 4 bleeds. If it was the parietal area, it had impact on motor. So you'd be looking at upper limb work in particular, but it didn't have impact on behavior or cognition or vision, right? If you've got a different type of lesion like that posterior watershed, we worry a lot about vision and we worry about neglect. So I had one of those babies recently as well. Baby had very dense neglect, but actually a normal motor exam. And so you want to be working with the team to get black and white and like move the crib so that everybody's coming in on the side they're neglecting, but knowing that they're not, that the posterior limbs look good, they're not going to have significant motor impairment. So you want to be working on the areas that make the most sense related to the regional injury.
And I would think, Terri, that the use of the visual tool at times of the MRI is an asset in conversation with parents to explain the very targeted
Absolutely.
therapy.
Absolutely. And of course, I always explain that in the newborn brain, it's a warehouse that's still under construction. So we have the capacity, particularly if you haven't taken out the deep nuclear grey matter, which are the system administrator of the whole warehouse. If you haven't taken that out, then we can potentially, you know, move things around a little bit. You know, we're not trying to rebuild, we're just trying to change the plan a little bit so that we can utilize these other areas. So, you know, I even say to the parents, like, just imagine you're building the house and you're going to have this big dining room and living room, and now you're going to have an open plan, right?
Mm-hmm.
So we've got to work on how to make that space work well.
Every house I look at now, I'll think of that if it's an open plan. And then last question that I see on the screen, can we accurately date the injury to brain using newer MRI techniques?
Yeah, so many people spend a lot of time, and we do believe that it's not accurate, but it's crudely. You know, for instance, if the diffusion, the hard thing is, do you have other markers to support this? If the diffusion is not very significant, but the T1 and the T2 is, you're in that latter phase of the evolution of the injury. If you've only got diffusion restriction and nothing on the T1, T2, you're probably in that earlier phase of the evolution of the injury. But, you're talking in days, not hours. We do wonder, and I think myself, when I see these elevated nucleated red blood cells now, I do get very concerned that these kids have been more than 24 hours old at the time we got them. Mm-hmm. And if they are bad, then I'm happy to go down to the scanner more quickly than I would have for a kid that took a big, cord prolapse or uterine rupture or something, where I would try to wait till at least the second or third day, even if the baby was badly injured. Because I think that those insults may well have already been underway for some time at birth. And I do think we need to keep trying to do a lot to help understand this, because there are going to be newer treatments coming too that are going to be in addition to hypothermia. And we've got to understand which of our babies are not likely to garner much benefit from hypothermia. We make it sound, because we like to be positive, we make it sound to every parent that hypothermia is going to fix everything. And, for a set of babies, it really does do that, but they're a pretty small set. And there's another group that it modifies, and then there's probably a group where we actually don't have much impact because the injury may well have already occurred.
And I think your word evolution applies there as well. The evolution of the therapies and the interventions, and just the greater understanding over time as you start to segment out. Not all injury is the same injury, not all patient is the same patient. And I think MRI plays a key place in that discovery as we start more
And always think
accurately
about
defined.
this, yeah. If your kid comes out and the base deficit's only -9, but the baby looks terrible and the EEG's flat, then there may have been some recovery of the baby. That may not be the worst base deficit that was there. There may have been some dialysis in utero that actually allowed some of the lactate to clear. And so you're already a little bit past. And that's why I like getting the whole electrolyte panel and the CMP panel. I like looking, I'm a clue finder. I like trying to find clues. So the more data I can have, the more I can try to put the clues together. And so I don't know why we wait. We have this big theory about maternal creatinine, and it's the maternal circulation. And I'm not sure that's true in these cases at all.
There's still much, much to understand, the finer nuances. But I think the work that you and your colleagues are doing are driving such broad improvement in understanding the injury and treating each injury as its own unique set of clues to define how you will respond to those clues. I think that's a great way to look at it. That was our last question. I'll give a last call. I know we're a little bit over. Thank you all for staying with us. Everybody hung in there. Terri, thank you again for your time. And we will be sending out a link to the recording of the presentation for anyone that would like to review it again, or if you would like to share it with your colleagues, or maybe get together as a group and view it on the recording. And please, if you have other questions, feel free to forward those to us. We would be happy to facilitate getting those to Terri and getting answers for you. And with that, I will give all of you the rest of your day back. Thank you from wherever you joined us. Thank you again, Terri. We do so appreciate your time and your expertise. Bye-bye.